improving and preserving the infrastructure of our safety net system for our hospitals to provide services to the Medi-Cal population. At the same time, we've received general fund savings from the hospitals for implementing this, and we are extending it an additional 30 months, which will generate roughly $12.5 billion of payments to our hospitals, a net benefit to the hospitals after paying for the fee of about $5.2 billion. It also will generate for the state for savings $920 million in savings for the state for children's coverage. So this is a very good program for our state and for our hospitals. We do need staffing to make sure that we're implementing the fee appropriately, to get approval from the federal government. We're still working for approval to set the managed care rates, to collect the funding from our hospitals, and therefore we're requesting 9.5 positions plus contract funds, and I hope you can approve this proposal. Thank you.
Thank you. Mr. Martin. Mr. Nelson.
Robert Nelson, Department of Finance. This proposal is aligned with the extension of the hospital fee. We support the extension of these limited term resources that are currently working with the existing hospital fee. I want to note that the hospital fee will generate a general fund savings of $255 million in 11-12 and $472 million in 12-13.
Okay, appreciate that. Mr. Douglas, I don't know if we, you addressed the question on page 38 of the 52-page report, and regarding the progress being made with the federal CMS regarding the approval of the
I'm sorry. So we are right now, we've submitted all, we've been working with the Hospital Association. There are many components to get approval. The first is getting approval for the fee-for-service payments, and we are in the final stages of getting approval. We've submitted all the requirements to demonstrate that we're paying no more than the federal limits, and we'll be walking through those the information over the next week, and we hope within the next month that it will be approved. Payments will then start going out, and then we'll be working over then the coming months on the managed care capitated payments and getting approval for those as well.
Okay, that's good news.
And we'll keep your staff, Michelle, involved and informed as we move forward.
All right, this one we're going to hold open. Number 10, money follows the person. This is on page 39 of the report, staff report. And the recommendation is to approve this item, and Senator Emerson has indicated that he would be supportive of that, so we'll take action.
So I'll just be very brief on this. Money Follows the Person's very important federal initiative that the state also strongly supports, of transitioning individuals from an institutional setting back into the community. And we also, besides getting additional federal funding when we do these transitions, we get 100% federal funding for any staffing related to this activities, and we're requesting extending 3 limited term and increasing it by 5 so that we can work with local community partners to engage them in these transitions to meet our goals and targets for the coming year of 330 additional transitions. We've done 692 so far. Incorporate the transition work into our managed care plans as we work more organized delivery systems. And there are many changes related to Medicare and the minimum data set requirements for informing and making sure that individuals in nursing facilities know about their right to move to the community. And so we want to make sure that we work with our partners on that. Thank you.
Thank you, Mr. Douglas. Okay.
Hello. Finance recommends approving this proposal to use $892,000 of federal funds to expand the Money Follows the Person grant program, as well as the requested limited term positions. And we would like to note that this is a rare opportunity to utilize resources provided entirely by federal funds to benefit the state general fund.
Mm-hmm. Okay. Public comment.
Deborah Doctor from Disability Rights California, and we support this program, but we would caution that the state has fallen far, far short of its goals for transitioning people, and would urge the committee to look into the issue of why so very few referrals are coming from nursing homes when study after study shows that about 20–25% of the people will answer yes to that question Q in the MDS 3.0. The programs report that they're getting very few referrals, and I don't think anybody is kind of monitoring or checking why is that. So that's a question we'd like to raise. Thank you.
We'll attempt to get the answer for you. Anyone else from the public? The recommendation is to approve it, and the record will reflect that Senator Emerson and DeSaulnier voted aye for that. Our last item is access monitoring program. This part.
Last year, as part of the budget, the legislature and the governor enacted payment reductions for many providers, and we worked this past year with our federal colleagues on getting approval for many of those payment reductions and doing rigorous analyses of current access to services for our population, both in terms of utilization, provider participation, and looking over time at how these trends have changed. As part of the approval, one of the requirements is to continue to monitor access to services, which the department is 100% committed to doing, to make sure that we rapidly respond in the events that there isn't sufficient access and make changes. Well, that requires resources to do a rigorous analysis ongoing and report transparently to stakeholders on changes in utilization, and be able to have a process where we look at beneficiary hotlines and calls, as well as other different indicators that demonstrate whether access is still being achieved. And so we're requesting authorization of 2 positions as well as contract dollars to do this work.
Okay. Oh.
Finance supports the proposal for the expenditure and the positions.
I just never want to overlook you again,
Thank you.
Kimberly. Any public comment on this item? We're going to leave this one open, so that'll move us to the next part of our agenda. And would ask, we're going to go to the Managed Risk Medical Insurance Board, Mr. Mibb. And these are on page 44. Actually, it starts on page 42, but the discussion items start on page 4. Casillas. So we're going to start on transition of healthy families, children to Medi-Cal, and Mr. Mibb and DHCS are going to comment on this transition. Mr. Douglas, are you going to begin, or?
So the administration is proposing the transition of the Healthy Families program to the Medi-Cal program. In essence, moving these children out of Healthy Families onto the Medi-Cal program and creating a Medi-Cal expansion up to 250% of the federal poverty level. I'll quickly lay out the rationale and the vision for this proposal. We really believe with healthcare reform and we need to make changes that continue to drive consumer-friendly approach to coverage and benefits, to streamline the administration. And this proposal has the benefits of doing that, consolidating the administration, making sure, as we have seen, the number of plans that work in the Healthy Families program and the Medi-Cal program have become more or less one and the same, that we can create more administrative efficiencies at the state level, at the health plan level. From an eligibility perspective, it creates a more streamlined approach that all kids are in the same program, as well as we think that this can create more stable plan choices, as Medi-Cal has been able to keep the same plans in the network as Healthy Families over time has seen changes in the plans that have been in the network. Now, this is a big transition, and as you've noted, we have many different pieces, different big proposals on our plate, and we have laid out a proposal here to do this in a way that ensures that we do it in a smooth way to transition over time, over a 9-month period, these kids from the Healthy Families program to the Medi-Cal program in a way that minimizes disruption in services, makes sure that we maintain adequate provider networks, and most fundamentally ensures that they have access to care. We believe we can do this, that we have looked at the overlap in the managed care plans. About 75% of kids are in managed care plans that contract with Medi-Cal. When we look at the provider overlap, there's a strong overlap in terms of the providers that contract in both programs. It is a change in the payment rate, and I'll acknowledge that there's a change in the payments, but a lot of that change in payment has to do with some of the value that the Medi-Cal program has in being able to be a very strong purchaser and reducing out-of-network costs for non-contracted providers, for hospital costs. that Healthy Families as a private purchaser cannot do. So we create savings also from Vaccines for Children program. We believe this is the right thing to do now. Healthy Families has been a great program. It has in many ways has been able to create increased coverage for kids and really transform both the Medi-Cal and Healthy Families program over time. But now's the time to start consolidating and creating a consumer-friendly approach. And we hope we can work with the legislature, with Mr. Mibb and stakeholders to do this transition in the right way, so that we make sure we do not impact any kids' access to services.
I want to hear from Mr. Mibb. Do you have any? I'm sorry. There you are.
Yes, I'm here.
Finance is confusing me. I know it's, again, as a mere mortal, it's hard for me to keep track of who's sitting where.
Musical chairs. Jeanette Casillas from Mr. Mibb, Mr. Chairman, members. Just wanted to share with you, while we understand the desire to consolidate programs and have efficiencies and, more importantly, streamline things for families, I think from our board's perspective at this time, we would have some concerns relative to access. We've been having communications with our plans, and this is something that the board had a position on last go-round. They continue to have the same position, and we would actually concur with the analysis that LAO has done on this issue.
Okay. It's a good segue.
Good afternoon. Jana Olsen-Morgan with the Legislative Analyst's Office. We have looked into this issue. We found that the governor's proposal does have merit, but we also raised several budget and policy concerns that we have with the proposal, and we suggested an alternative that may address some of these concerns. Firstly, the merit that it does seem to improve continuity of care for some families by consolidating those health programs from 2 to 1, especially families with varying incomes who may be switching between being eligible for Medi-Cal one year and being eligible for Healthy Families will experience less sort of changes, less churning. This could also help families who currently have one child in Healthy Families and one child in Medi-Cal by bringing more sort of consolidation to that. We also found that it would implement some of the changes required by federal health care reform early, and that could be a benefit. However, we did have some concerns with the proposal. Specifically, the healthcare services for some HFP enrollees will certainly be disrupted during the transition. It may impact the access to providers. And we also think that the proposal more broadly should be considered in the context of healthcare reform. So bearing in mind our concerns, we do have a recommended alternative. We'd like to suggest that the legislature consider shifting the kids that are referred to as bright line kids. These are the kids in families with incomes between 100 and 133% of the federal poverty level. And these are the children who would become eligible for Medi-Cal in 2014 under federal health care reform anyways. So we suggest that this population, this subpopulation of Healthy Families, be considered a pilot program and be switched in budget year, and that will give us a chance to sort of look at the impact on the access to providers, iron out some of these wrinkles that could occur, and then go forward and consider more broadly the future of Healthy Families, perhaps in policy committee and in the context of health care reform, because the state does have several different options that it could take. The Healthy Families program could exist as is under federal health care reform as a standalone program. It could be switched into Medi-Cal, or it could be run through the exchange in several different ways. So we believe in the context of federal health care reform, this discussion sort of warrants a broader discussion. We do want to be upfront that the fiscal effects of our alternative are certainly less certain. A lot depends on Mr. Mibb's ability to reach that suggested rate reduction. If they can reach that rate reduction, our alternative is actually cost neutral. If they cannot, then the cost savings would certainly be less certain under our alternative. Thank you.
Robert Nelson, Finance. We support the proposal. And this piece of the proposal, the shift, would achieve a $91 million general fund savings starting in 13-14. In addition to that, it would simplify eligibility for coverage for children and families, as well as lower costs for families within certain income levels, retroactive payments for Medi-Cal, and enhanced mental health services. One of our concerns with the Brightline proposal is that there's a recommendation based on the phase-in versus the redetermination. The governor's proposal is based on a phase-in for provider readiness. Our concern is there might be some phase 3 children that could possibly go into Medi-Cal during a phase 1 period, and then we won't have providers ready at that time for them. That's all. Thank you.
Okay.
I just wanted to add that moving just the Bright Line kids also eliminates many of the benefits that are part of this proposal, such as you'd still have kids bouncing between Healthy Families and Medi-Cal, as is currently the case. You wouldn't achieve the administrative savings. You'd also be moving about 20% of the Healthy Families kids into Medi-Cal, reducing the bargaining power of Healthy Families to achieve the rates that they've been able to achieve.
Do either of you have a comment on the LAO's proposal, or pretty much agree with finance?
On the LAO proposal, the board, this has been presented to the board as well. We had a board meeting yesterday. The board has talked about this on 2 occasions, as well as last month. The Urban Institute did an analysis on this very topic, came out with the same conclusions. To proceed forward just with the Bright Line kids, this is something that the board supports.
Mr. Douglas, anything?
Other than, I mean, the Bright Line, I would just say it's, it gets back to, we think, given the robust nature of our plans and the overlap and doing this slowly, that we can move all of them carefully over a 9-month period, and there are many Knox-Keene requirements, other requirements on our plans that will ensure access to services that build into this. But doing just the Bright Line will require the same level of resources, requirements to transition the population, whether it's 200,000 or the whole population. And then given the fiscal environment and healthcare reform, if we're going to do this, we need to do it in a way that deals with the whole population.
I just want sort of a combination of 3 of the questions that staff has presented, and I offer free relationship advice in the spirit of what I'm asking here. So number 2 is just to talk about how both of you are coordinating to implement this, how that's going, and then both the short-term and the long-term obstacles were 3 questions that Michelle prepared for you. And I wonder, Mr. Douglas? How are we coordinating?
Well, I would say, first overall is that the department and Mr. Mibb has always had a great relationship on working, and we're working very closely on CalHERS and other initiatives that we have over the years. This is, just fundamentally, it's a very difficult proposal, and what the administration is proposing. And we are trying to work with Mr. Mibb, and I think they're trying to work with us, but it's a very difficult proposal on what we're proposing. So.
And the short-term obstacles and what long-term? I want you both to feel like you can express yourself freely here with Dr. DeSaulnier.
If this proposal is enacted, we would need to work very closely with Mr. Mibb, and I expect that we would be able to on making sure that we get information about the providers that these children are seeing, so that we can, similar to what we've done with seniors and persons with disability, that we connect the children to the same providers, that we work with our plans to outreach and get those providers into their networks like they have done previously. We'd work very closely with Mr. Mibb on making sure that we transition the Maximus contract over to the department so that we continue to have this single point of entry. And I expect all that will happen. Right now, as Jeanette said, Ms. Lopez, that they're in a different place in the board, and we respect that.
Anything? Senator Emerson?
I would echo what Mr. Douglas has said. It's a difficult proposal. Whatever you all decide, we collectively will be at the table to do what we need to do.
That's the spirit. I feel we're getting closer here. Senator Emerson?
I do believe you may be practicing without a license there, Dr. DeSaulnier, but that's okay. That's for another discussion.
Given my own personal, never mind.
Although we're not discussing the gross premium tax today, that tax was enacted in 2009 on the understanding that it would be to support a viable Healthy Families program and not to dismantle it. And I just want to put on record that the Republicans will not be voting to continue that tax if it's not used to continue with healthy families. And I also want to make one observation that I think it's highly unlikely that access to care will be achieved in the healthy families will continue once you go into the Medi-Cal program, and also that the 43,000 kids that are in the Medi-Cal fee-for-service, where Medi-Cal's own data shows there was inadequate access. So I think this poses a real problem, because once the rates drop, then there's going to be less access in there. So.
Okay, thank you. Public comment. Mr. Mecca, yeah, we've got two seats. We've got the podium and the seat. Maybe we can... Thank you, Mr. Nelson.
Thank you, Mr. Chairman. Senator Frank Mecca, Executive Director of the County Welfare Directors Association. We're in support of the governor's proposal, and the reasons for our support have been pretty well laid out in the agenda by Mr. Douglas and by the LAO. I'd just like to underscore, from our standpoint, the key advantages. First, we think that since such a large proportion of the children are likely to be Medi-Cal eligible under health reform, this actually does give us the ability to get a head start on what is a daunting task for implementing health care reform, no matter what we do. We also see a benefit to clients. You've heard already about the unifying families, where we have children who move from program to program, or children who live in families that have members in different programs. There's also a benefit to children who need mental health and substance abuse services. We think that there's a significant possibility that the potential access to those services would improve under the proposal vis-a-vis current law. We also think the proposal is achievable. During the recession, county human service agencies added hundreds of thousands of people to the Medi-Cal rolls. We added millions of people to the rolls of CalFresh and CalWorks. We process about 400,000 applications for the major aid programs now. This proposal will add about 20,000 per month. Based on our discussions with the administration, given that the rules in the Healthy Families program are significantly simpler than the Medi-Cal program, we think, we're quite confident that we could work out an approach to absorb these cases into Medi-Cal in a fiscally neutral and certainly achievable way. Like Mr. Douglas, we know this is a major proposal, and we're certainly aware that this is not easy work. There are transition issues, clearly, and there are continuity of care issues that really aren't sort of the central focus of the county human services directors, but we're not unaware of them, and we look forward to working with the legislature and the administration to work them out, because we think that there's a lot of merit in making this proposal happen.
Mr. Chair, Vanessa Kahina with Western Center on Law and Poverty. Here to be supportive of the concept of moving the Healthy Families children up to 250% of the federal poverty level into the Medi-Cal program. However, we do have concerns about access and continuity of care that are outlined in our letter. We believe that those are more related to issues existing within the Medi-Cal program as opposed to maintaining two separate and unequal programs where you have children in different income groups who are seeing different levels of access as a result of their income and where they fall in that. In terms of laying some context for this is a different position that we're taking and is closely aligned with the position we took last year in the May revise, but to say that in the context of the duals and the seniors and persons with disabilities and those transfers, that this should be more of a plan-to-plan change. However, there do maintain concerns in terms of provider access and network access and adequacy. So we have to see those addressed before we even begin to embark on this. As a result of that, the timeline might be in flux in terms of what we're discussing, but to take you back as early as 2009, when Governor Schwarzenegger blue-penciled funding for the Healthy Families Program. And the plans did the right thing. They got together. They said, we're going to do the MCO tax on this. However, if we solidify and cement this group into entitled benefit as we go forth into 2014, when we don't really know what's going to happen, and we have to ask ourselves, for kids up to 250% of the federal poverty level, can we ensure the kind of cost sharing that they've had in Healthy Families, which incidentally has gone up year after year after year as a result of our budget? So for those reasons, to solidify and cement the cost sharing and the entitlement and the benefits that the children would see in this program, we remain supportive of the concept and ready to work on this.
Mr. Chair, members, Sean South, California Primary Care Association. We oppose the proposal as written. We do echo the sentiments of Senator Emerson that we believe this will create great access problems. As Director Douglas said, Healthy Families is a good program that works, so why would we want to do anything that would negatively affect the kids that are currently in the program? We do echo the thoughts of the LAO and think if you're going to move a population, the Bright Line kids make sense as set forth in the ACA, but the program, the additional kids that are in the program should remain in Healthy Families. It is a viable program, it is a successful program, and it is a program that serves the needs of our children and should continue for those reasons. Thank you.
Thank you.
Association. We have serious concerns with the proposal to move these children. You heard and discussed this morning the significant problems with the dental managed care program in Sacramento, so severe that immediate action has had to be taken. This proposal will allow DHCS to contract with additional managed care plans for dental care in the Medi-Cal program and make enrollment in all of the managed care plans voluntary for the existing Medi-Cal enrollees. We view this as an expansion of managed care in dental, and since there is no good model that works well, we don't see any reason that should be expanded in any other areas. Thank you.
Thank you.
Can I just quickly respond on that point,
Sure.
just to clarify on, since this issue is of importance. What we're proposing here, this gets back to the fundamental goal of this proposal to ensure continuity of care and as much as possible connecting these children to the same provider. Healthy Families contracts with dental managed care plans in over 30 counties throughout the state. What we're proposing to do is to contract with the same dental managed care plans and allow those children who are in those dental managed care plans in Healthy Families to stay with that dental managed care plan in Medi-Cal. They will be able to voluntarily default back into the fee-for-service dental system in Medi-Cal if they so choose, or stay in managed care. No existing Medi-Cal children will be put into these plans. They could voluntarily choose to go into it, but we won't be putting them in. So I just want to make sure it's about the fundamental goal of minimizing any disruption.
Any committee member who has a relationship with the Dental Association care and comment?
Yeah, but you're assuming that they're going to stay there, but you're going to reduce the fees by a huge amount. That's why we established Healthy Families, was to help more children in the process. Now what you're doing is you're going to put them in a Denti-Cal program that has lousy reimbursements that don't even pay any of the costs.
We will take that as an editorial comment, Mr. Douglas.
And that was given as an editorial comment. Thank you very much.
A strong personal one. Ms. Jenna.
Thank you, Mr. Chair and members. Carolyn Jenna with the California Medical Association. We do have an opposed position on this proposal. We would support the alternative that's been offered by the Urban Institute and the LAO, and that's to do the Bright Line transition. We think that's appropriate. It's going to have to be done within 18 months, so that gives us a good pilot program and population to work on and to see how we do this. Moving almost 900,000 kids now, given the issues with access in Medi-Cal. I mean, there have been numerous studies. Medi-Cal enrollees use emergency rooms at double the rate that the rest of us do. So now we're going to take kids in a program that, from our physicians' experience, has been better on both the provider and the patient end, and put them into one that has decidedly less positive results. So again, we would urge you to reject it. Thank you.
Helen Roth Dowden, representing SEIU Local 1000, the state workers. Healthy Families has always been a state program. It's different than Medi-Cal, and why we think that there is an issue, and we think that maybe the Bright Line kids, that certainly makes sense, and we think that that would create greater continuity for kids who are falling off and on because of their income. We think that the collection of premiums really is something that's quite different, and the counties do not have the same kind of experience. We've had a successful program with Healthy Families, and we think it looks a lot more like the exchange than it does like maybe Medi-Cal. So we want to raise these concerns at this hearing, and we hope they'll be taken into consideration. Thank you.
Mr. Chairman and members, John Valencia representing VSP Vision Plan. We're a not-for-profit HMO focused on vision care delivery only. We currently cover 700,000 of the 900,000 or so children in Healthy Families. I guess our reaction to the proposal is one largely of disappointment. Each time eradication of Mr. Mibb and Healthy Families has been raised, consistent with our not-for-profit structure, we've responded by redesigning the benefit, by reducing costs within the program. It runs somewhere around a per member per month premium structure of about $2.37, $2.47 a month. I seriously doubt that, given the level of delivery of care that we provide, which is double Medi-Cal, and there will definitely, according to Senator Emerson's observation, be an access to care issue if there are transfers. We also don't think that Medi-Cal will be able to achieve the savings that we've generated. Now, admittedly, vision care is but a fraction of what the overall care delivery objective of Healthy Families is, but it really is one of disappointment because we've risen to the challenge, I think, along with the rest of our colleagues in managed care. It is a different program. It works very well. We'd encourage, at the very least, the LAO alternative to be explored. And we hope to be meeting with the director real soon to try and offer up yet another alternative if the eventuality is a consolidation of the programs.
Thank you, John.
Thank you.
Natalie Cardenas with Anthem Blue Cross. We are a Healthy Families provider in 52 counties in California, so we have a significant, very grave concern with this proposal. We are particularly concerned about the impact of continuity of care for our enrollees should this transition be implemented. We expect to experience significant membership loss as a result of this proposal. We provide care to about 200,000 Healthy Family enrollees in California. We expect to lose about 85,000 of those at the minimum should this transition take place. These enrollees will likely revert back to fee-for-service, particularly in the rural counties, of which we are a significant partner with the state, providing Healthy Family services to those rural citizens. We expect that this proposal will also make it very difficult for our enrollees to maintain the same level of care and the same access to providers. Where we do provide services for 52 counties in California in the Healthy Families program, we are only in 12 counties in the Medi-Cal program. So we expect for those 40 counties that have Anthem Blue Cross as a provider, they won't have that in the Medi-Cal field. So those children will be forced to go to a different plan and probably to a different provider, and we see that as a significant problem. So for those reasons, we oppose this proposal.
Thank you, Ms. Cardenas. Mr. Shannon?
Mr. Chairman and members, Tim Shannon, representing the Children's Specialty Care Coalition. We're opposed to the proposal as presented. Like others, we think that there will be access problems created by the proposal. Senator Emerson is spot on. We agree with the CMA and others as well that the recommendation being offered by the Legislative Analyst's Office is a good compromise. Just moving the Bright Line kids over, that could serve as a valuable pilot project to see if this proposal indeed is going to create problems. And I think that is the way to go. It's a good middle ground. Thank you.
Thank you.
Mr. Chair and members, my name is Autumn Ogden. I'm with California Coverage and Health Initiatives. We're a collaboration of children's and community health initiatives along with 17 outreach and enrollment partners across the state. I'm also here with my colleagues from the Children's Coverage Coalition, which is Children Now, United Way, Pico, California, Children's Partnership, and the Children's Defense Fund, and we are in opposition to this proposal. We feel the proposal will move far too quickly and put at risk the health care of children currently in Medi-Cal and those moving from Healthy Families. The Department of Health Care Services' own report issued last year addressed access as an issue of concern, noting that only 6% of Medi-Cal children under 20 received at least one physical or clinic visit, as compared to the national average at 90%. And we oppose this change, but we do support the alternatives as laid out by the LAO and CPCO and others to move the Bright Line children. And we also would like to add in, we'd like to see additional safeguards addressing access issues, implementing a transition, and monitoring a plan. Thank you.
I'm Michelle Stoll-Parmensky with the Children's Defense Fund, California, and the 100% campaign. We are here to oppose the governor's proposal to eliminate healthy families and move those children into Medi-Cal. We've heard a little bit about the Urban Institute report, but I just want to provide a few more details on that. The 100% campaign last year commissioned the Urban Institute to look at the policy options for healthy families, children, particularly focused on what's best for kids. And they found that there are significant disadvantages to moving the kids from healthy families to Medi-Cal, including reduced access to needed care for many kids, the loss of Mr. Mibb's important role and focus on children, and the risks of a disruptive transition. So as a result, the Urban Institute recommended an alternative of shifting just those Bright Line kids into Medi-Cal in the short term, and then monitoring those results and waiting to make a decision on the rest of the population. And they also recommended some measures to protect and safeguard access to care, and making sure that we're rigorously monitoring the results for those kids that are transitioned. So we agree with the Urban Institute and the LAO recommendation as laid out, and urge you to reject the governor's proposal and instead adopt this alternative. And we believe that this will allow the state to assess the results of that initial transition and make a broader decision in a way that's good for kids. Thank you.
Thank you, Michelle.
Stephanie Hodson with United Ways of California, and we're opposed to this proposal. Because of the potential for children to have their care interrupted, we would support the partial transition plan of the Bright Line kids that has been laid out both in our letter by the LAO and by others. Access to care is our main concern, especially in the counties where we know there's currently insufficient Medi-Cal providers or where there are no Medi-Cal managed plans currently. We understand that DHCS has done an access analysis, and they found that the majority of Medi-Cal plans participate in both programs, but that doesn't necessarily ensure that there's an adequate network of providers within that plan that would be willing or able to serve the current healthy families kids at those Medi-Cal rates, nor does it clarify any specific geographic regions of the state that might experience an absence of plans or providers, so that's a concern for us as well. So we would urge you to reject the proposal as is and would support the LAO's alternative proposal with those additional safeguards that were laid out in our letter.
Thank you.
Hi, good afternoon. Jessica Rothar with Pico, California. We are the largest grassroots organizing group in California, representing 450,000 families from Placer to San Diego. And I know some of our folks were just in to visit you recently.
They frequently are.
We join our colleagues in the 100% campaign in the Children's Coalition in opposing this proposal and recommending instead the Bright Line alternative. PICA is particularly concerned about the 230,000 children who have Kaiser coverage or in counties without Medi-Cal managed care who will have to change their plans and may have to change their doctors. We're also concerned about the loss of Mr. Mibb's focus on children and the more cumbersome enrollment and retention system in Medi-Cal. Our families talk about 6-week waits to get into clinics and talk in an offhand way about the fact that they just have to go to the emergency room if they're sick. That's not the kind of care that we want for children. The Urban Institute report did acknowledge that there are some children who might benefit from the transfer, and those are the Bright Line kids, the children for whom the the having no premiums and copays would be very helpful. I want to just briefly share one story from one of our leaders in Stockton. Her name is Mi Yang. She has 2 young sons. Both are on healthy families. Her 8-year-old was recently found to have signs of early heart disease. He's had the same doctor at Kaiser since he was 8 years old, and that's why they noticed these signs of early heart disease. Mi Yang and her husband are now getting tested to see if it's a genetic problem. She is beside herself at the idea that her son might have to change doctors. So we hope you will reject this proposal. Thank you.
Thank you.
Good afternoon, Mr. Chair and members. Kathleen Hamilton with the Children's Partnership. We're also opposed to this proposal, which, as you know, proposes to transition nearly 1 million children in a very aggressive time frame. So we agree with our colleagues that instead of attempting to execute that daunting of a transition, that what we would suggest is proceeding with the transition of the Bright Line kids. As you've heard from our colleagues, I won't repeat that. Those comments, but do want to just point out and remind the committee that the Bright Line kids are already required under federal law to be transitioned into Medi-Cal in 2014. So we have a rare opportunity to actually do that portion of the transition in a timely, thoughtful, monitored way. So we would support the transition of the Bright Line kids as long as it's accompanied with attention to critical access and transition issues, that safeguards are put in place to protect families and children, and that there's a monitoring plan that we're able to review and monitor on an ongoing basis so that we know how the transitions are proceeding. Thank you.
Thank you.
Thank you, Mr. Chair and members. Teresa Stark with Kaiser Permanente. We are proud to be a major provider in the Healthy Families Program. We have nearly 190,000 enrollees. Regrettably, we are here in opposition to this proposal as well, and we would echo the comments of many of the folks who already spoke with respect to concerns about continuity of care and access to care, and we would also associate ourselves with the Legislative Analyst's Office on the recommendation to look at this proposal through the lens of health reform and the need to have a very robust policy discussion about what we want the long-term vision for kids coverage to be in California as we implement health reform. As the LAO said, there are many options. Medi-Cal is only one option. Kaiser Permanente believes that the exchange is also a viable option for these kids. It will look much like Mr. Mibb, like Healthy Families does now. So there are multiple different options, and I think the bottom line is we need to have a very thorough discussion about the pros and cons of all of these options. So we would urge your opposition. Thank you.
Thank you.
Kelly Brooks on behalf of the California State Association of Counties. We're supportive of the administration's proposal, primarily because we see the enhanced benefits for kids, particularly in the behavioral health services area. So kids that would transition back to Medi-Cal would become eligible for EPSDT services, which are much more comprehensive than the mental health services they receive under the Healthy Families Program. Additionally, the alcohol and drug services provided under Medi-Cal far surpass what has been historically provided in the Healthy Families Program. About 100 kids annually access alcohol and drug treatment services now in the Healthy Families Program. That's dismal. So we think there's opportunities for Medi-Cal to really expand access into critical areas. I would put a pin in issues around EPSDT. Starting on July 1, counties are going to have 100% share of cost of that program. So we need to make sure, as we're building our realignment budget for next year, that we have a really good estimate of the number of kids that are going to be transitioning to the Healthy Families Program, so that when we become fully responsible for the cost, that we actually have the resources available to us. And we recognize that there are concerns about provider access, and I would be remiss if I didn't recognize that's a huge issue in our rural counties. We want to continue to work with the administration, the legislature, and the other stakeholders as this moves forward. Thank you.
Thank you.
Mr. Chair, members, Randy Perry with the California Children's Hospital Association. Again, for us, it's a continuity of care issue. We simply ask that this body proceed with caution in this area. 900,000 kids moving over is a concern. Loss of docs and some of these folks being mid-treatment is a concern to us. Thank you.
Mr. Perry. Anyone else? Seeing no one. Again, Mr. Douglas, congratulations on your effort in stimulating discussion. And I find myself being sympathetic to most of the public testimony, actually all the public testimony, both particularly from the counties in the things that they see good about it, but then in the other speakers about a program that's been very successful that was started, this is a Wilson administration, I think, beginning proposal that was after, like so many things, long-term prevention, starting with access and robust services to disadvantaged kids. So here we are 15, 20 years later. We know the value of the program. So just, I'm a great deal of apprehension, even along with the comments of my friends in county government. So we're going to leave this open, but we'll have a lot of discussion between now and when we move on it, probably in May. Thank you. So we'll move on to the next item, Healthy Families Program Rate Reduction. This is also to hold this open. Do you have anything to? No?
The only thing I can share is we are in the process of rate negotiations now. We're scheduling calls, having internal discussions with our plans. I think to give you a sense of context, I would share with you that what we do in Healthy Families is we have a rate negotiation process. It is not a rate setting process. We have a very unique methodology, long history behind it about the way the process works. It takes into consideration a combination of the health, dental, and vision rates that are being proposed by county, by region. So it's not just a matter of picking out a health plan rate and saying we're going to reduce it by 25% or the dental or the vision. So it is complicated, and more importantly, it is negotiated. It's not something that we just say we're looking at this line item and we're going to reduce it by X amount. I would tell you that the benefits in Healthy Families compared to Medi-Cal are very, very similar. We don't have 24-hour shift nursing. We don't have non-emergency medical transportation. But based on our legal office assessment of the benefits, at the high level, they're the same. What is different is the delivery system. And long-standing history, it was the legislature's decision to do it in a managed care model. So that's all we do is managed care. So in our managed care contracts, we include everything. We defer to our plans for all comprehensive and coordinated care. I would tell you that the other thing that's in our contracts is we have, in our model, we have a medical loss ratio. So we set, that's one of the things that we do say. So X% of every dollar we give you has to go towards medical services. The other percent that's not medical, it goes to administration, it goes to reporting, it goes to profits, it goes to a combination of things that are allowable under the requirements or the jurisdiction as defined by DMHC. And we contract with DMHC to actually go in and assure that these MLRs are being are in compliance with the contractual standards. So it is something we have in there, it is something we monitor, and we also audit. Given that, along with the last several years' rate negotiations with our plans, we have negotiated with them for the last few years a couple of years of rate freezes. So between the rate freezes and the minimum the medical loss ratio requirements, the plans have indicated to us they are not in a position to take a 25% rate cut, not with the benefit package that we are expecting them to deliver and hold them accountable for. We were not entering into this discussion to do negotiations on another series of benefits or any other changes about how we do our rate process. So with absent that, with everything else holding steady, they're not in a. What they have indicated to us is that they're just not in a position to do that. Generally, when we have had to do a rate freeze and they have high cost cases coming through or just health care expenses in general increasing, the way that they've achieved this in some years past is by reducing the broader networks that we used to have. So for Anthem Blue Cross, for example, we used to buy their commercial network. Blue Shield is another commercial plan. We had Blue Shield all over Northern California. We don't anymore, but we did at one time. So as we have had to also pare back what we had the ability to compensate or reimburse we have had to narrow down either the number of choices that members had in a given county and or some narrower networks. And we believe at this point we are as narrow as we feel safe providing, in terms of contracting for and requiring of the plans. So we believe, and what the plans have asserted to us when we talk to them about a rate reduction, is we can achieve it maybe if we narrow and we skim back to the bare minimum our networks. Now that raises many questions. It raises the question on whether that is acceptable, if that would be an acceptable level for even licensing under Knox-Keene. All of our plans are required to be Knox-Keene licensed. Any material modifications have to be approved and reviewed by DMHC. We do our own monitoring of access as well, but it's not as comprehensive of knowing all the different payer sources and the networks, and for any given doctor, how many plans that they contract with. So it raises much broader concern. We believe that we are paying more. We believe that we're paying more for greater access. We have statewide access in managed care. We think that those are great successes. You have heard, I've been asked many a time, but I think you heard directly from the plans, the networks are not the same. We know that. That's why we're paying more. That you've got the Kaiser network. You have the Anthem Blue Cross network. You have Blue Shield that doesn't participate in Medi-Cal. So it goes on, and even the plans that do match over, we have been instructed, or we have been informed by these plans that our networks are broader. So from that aspect, I would tell you that I could not assert to you that we will have successes in that type of a rate reduction. And with the dental plans, they didn't even want to have the discussion.
I know how difficult they can be to deal with, or one of them at least, some of them. Ms. the legislative analyst, you have some differences, or?
Primarily, we are just concerned that the administration's estimate of the savings for budget year could erode. As Ms. Casillas has described, it's a very complex negotiation process, and if they can't reach those rate reductions, then we'll certainly see a drop in the savings.
Finance?
Audrey Bezos, Department of Finance. We'd just like to point out that the state is paying approximately $90 million more each year to provide what's essentially the same benefits to healthy family kids compared to Medi-Cal kids. And given, the cuts we're faced with this year, we think it's appropriate that healthy families would attempt to reduce rates to Medi-Cal levels, which are actuarially certified, in order, we think this is a reasonable approach to achieve savings. Thank you.
Okay. Public comment.
Thank you, Mr. Chair and members. Nick Luizos with the California Association of Health Plans. Let me first say that our member health plans support many things that are in the governor's budget, and we look forward to future hearings where we get to talk about the managed care population and service expansions and share our views on those issues. Unfortunately, this is one proposal that we must oppose. We don't believe that a rate reduction of this magnitude is founded. We don't believe that it's sound. And in some respect, we also believe it's counterintuitive to what the department's trying to accomplish in other managed care expansions, particularly the rural expansion, where the department has said that they'd like to use or base a network of providers on the Healthy Families model that exists in those rural areas to the extent that they exist. Cutting rates by 25%, certainly you can imagine that compromising that structure. Other points that haven't been raised. The department's made it clear that they intend to pursue this rate cut regardless of whether the Healthy Families transition to Medi-Cal occurs or not. We do not believe this is appropriate because of some of the benefit design differences that have been mentioned earlier and that are listed in your analysis. Also, if the Healthy Families to Medi-Cal transition is enacted, it does include a 9-month transition period where plans will be paid significantly less for no valid policy reason from our perspective. Finally, just the rate cut is just massive in its scope. It's not reasonable to expect that plans will be able to absorb these costs or easily amend their provider contracts with our participating providers in order to absorb it. reducing rates to providers, if we're forced to do so, at those levels, you can imagine there'd be a reaction to that at that level that could compromise access to the program and continuity of care. So we're opposed to this proposal. We hope ultimately that it's rejected. Thank you.
Thank you.
Thank you. Carolyn Jenno with the California Medical Association. We, too, oppose the proposal to cut the rates by 25%. We think as a separate proposal, then the discussion about whether or not we eliminate Healthy Families and move it into Medi-Cal, should the legislature decide that you don't want to do that, as we would urge you and many others who've testified today would. In fact, we're kind of doing the same thing if we cut the rates to Medi-Cal levels. I mean, we've heard testimony regarding the networks and the difficulties for establishing those with that reduced amount of funding, and that does make it all the way down to our providers, who then have to make the really tough decisions about whether or not they continue to see their patients that they've had long-standing relationships with and often can have complicated medical conditions. So again, network adequacy and ensuring this continuity of care for these patients, we're talking about a lot of people and a lot of kids here, and we just think this is a bad idea right now. We'd urge your opposition.
Mr. Chair, members, Randy Perry with California Children's Hospital Association. We simply ask you reject on this one.
Nicely said, Mr. Perry.
Natalie Cardenas with Anthem Blue Cross. We, too, oppose the 25.7% rate cut for this program. Whether you, as mentioned before, this is a proposal that stands alone, so whether the Healthy Families program survives in its current form or is dissolved through its transition to Medi-Cal, this rate cut is going to stand alone, and we really strongly feel that this will jeopardize our participation in some counties and probably for many other plans in the Healthy Families program. We also feel that it's somewhat counterintuitive to some of the other proposals that we'll be talking about in the future with expanding access to managed care, particularly in rural counties. As I mentioned previously, we are a major provider of Healthy Families in a majority of the rural counties in California, and we stand alone in that. In many cases, we are the only Healthy Families provider in rural counties, and we do that in the managed care model. If you destroy a managed care network by a 26% rate cut, what are you going to have to build upon to expand managed care into rural counties and to other parts of the state? So for those reasons, we oppose this portion of the proposal. Thank you.
Thanks, Ms. Gardner.
I'm Michelle Stoll-Prevensky from the Children's Defense Fund, and on behalf of the 100% campaign and the California Children's Health Coverage Campaign, we oppose this proposal, and I'd like to echo some of the earlier comments and just say that we're worried that this proposal could adversely affect children's access to care. Thank you.
Thank you, Michelle.
Mr. Chairman and members, Tim Shannon representing the Children's Specialty Care Coalition. We too think this will have a significant impact on access, and we oppose the proposal.
Thank you, Tim. Well, the recommendation is to leave it open, and we'll continue to have the discussion. It does seem if this is approved, the prior, but for all intents and purposes, you have eliminated Healthy Families. So, but we appreciate your pursuing the good fight in spite of how difficult it is. Last item is the transfer of Mr. MIB programs to the Department of Health Care Services. And this is on page 52 of the 52-page report. This is back to my practicing without a license. Is that what you're suggesting? How are things going?
So this, Audrey Bezos, Department of Finance, this proposal would eliminate Mr. MIB as a separate state entity beginning in 2013-14, along with the shift of Healthy Families population to Medi-Cal, which is as far as the number of people served by Mr. MIB, that is the majority of the people going to DHCS. And then in addition, Mr. MIB and PSIP will both essentially be eliminated once the exchange comes online, and those people, that population, is able to seek benefits through the exchange. So we believe that it would be appropriate for the remaining two programs, the Access to Infants and Mothers and the County Health Insurance Program, to move over to DHCS, since they're really two smaller programs than Mr. MIB, so we felt in order to achieve efficiencies, it was appropriate to move those over to DHCS.
Hello, Mr. Martin.
Sean Martin with the Legislative Analyst's Office. I mean, since we haven't seen the trailer bill yet, we're withholding recommendation, but In terms of a rationale, as it says in the agenda here, it's unclear why these programs would be shifted to DHCS for 6 months prior to elimination, when in some cases that logically they would be eliminated as a result of federal health care reform.
Yeah. I think the thinking behind that was because so much of the population that Mr. Mibb oversees would be shifting to DHCS in 1213, that it would make sense to basically be able to give that over to DHCS. And it's the hope that those two programs, the staff that oversee those programs would also go over with DHCS, so it wouldn't be that DHCS is learning how to oversee a program, that the staff would go over with the program and would able to oversee the transition of those people into the exchange should they not be able to enter January 1st. If there's a transition period that's needed, that they would be able, the same people that oversee the program now would continue to oversee the transition of those people into the exchange.
Public comment? Jenna, you get the award for public participation today. Every item you've...
Right. I'll make this one quick. We don't have an official position on this proposal, but just wanted to offer the comment that in how Mr. Mibb operates these programs, we really, really appreciate the accountability and the sunshine and the monthly reporting that they engage in that really helps all of us as advocates on behalf of providers and patients to know, what the status of the programs are. And we'd like to see that happen, as well as hopefully see the staff move over. And we've been in discussions on that with the department about this proposal, as well as the programs from DPH that are proposed to be moved over. So we're hoping to see that as well, so that the expertise and the brain trust moves along with the program. Thank you.
Good afternoon. My name is Lucy Quachinella. I'm here today on behalf of Maternal and Child Health Access. We don't have a position on this particular item per se, but we did want to highlight that to the extent that the Access for Infants and Mothers program is part of this or related conversations, there are some key issues. One of them involves what would happen with the eligibility and enrollment for those infants. In some of the informal descriptions that we've heard from the department, it seems that there's a vision of changing the existing insurance code provisions that deem those infants eligible to the Healthy Families Program for their first year. And we think it's very important that that deeming, that automatic enrollment for the first year, really be preserved, whether it's in Healthy Families or Medi-Cal. We think that's very important, so we just wanted to flag that for both agencies. A different but related issue concerns the eligibility rules that govern the mothers. After all, this whole proposal, this whole concept of shifting programs and or winding down certain administrative agencies is being raised in the context of federal health care reform and in the name of streamlining and consolidating and making things simpler and easier. And there are many examples of how the eligibility rules for the Access for Infants and Mothers program are actually much more restrictive, much more burdensome for the pregnant women who have income from employment up to 300% of poverty. So we would hope that any conversation going forward would align those rules to the less restrictive provisions in the Medi-Cal program for pregnant women. It just makes sense. Thank you.
Okay, thank you. Well, I appreciate Mr. Douglas, not all kidding aside, your attempt to, and the administration's attempt to prepare for health care reform in a thoughtful way. But it is a little odd sitting here and looking particularly this last section where you had a Republican administration here in California almost 20 years ago that wanted to focus on performance standards for poor, healthy for families. And at least my supporting of federal health care reform was to get cost controls, which I'm somewhat afraid that there's not enough of them in there, so we're going to try to do more, but at the same time we're not doing that completely at the expense of service, particularly for the most vulnerable Californians. And as the three of us keep hearing the recommendations from the administration, it's hard to miss the fact that a lot of this is going to affect women of color who have children and or have no partner. And it's just the cumulative effect as we go through this on those clients is particularly problematic, to say the least. So with that, appreciate you being here and appreciate all of your time. Senator Emerson, very much appreciate you staying and putting up with my sense of humor, and we are adjourned.
I just wanted to note that that's just your Republican side coming out there, which is refreshing to see
I was
that
a
you're
Wilson
concerned.
appointee twice, I admit it.